Everybody. We'll start now our last session in this day. It's a case-based review about breast imaging in young women. It's my pleasure to announce the first speaker, Professor Shilpa Lad, Consultant Radiology, Breast Imaging and Interventions in a Medical Center, Mumbai, India, Core Committee Member, Breast Imaging Society of India, former staff radiologist, Women Breast Health Center, the Ottawa Hospital, University of Ottawa, Canada, India. She will give us a talk about the young female breast case review.
Okay, thank you very kindly for the kind introduction, and thank you to all of you for coming back after lunch. So little tweaking in the title, cancers in the young female breast, simply because we are seeing so many of them that now everything has become in relation to ruling out cancer in a young woman. Okay, so in context to that, we will speak. As always, I dedicated my talk to my beloved Sadhguru, Sri Vaman Rao Pai. And the love for Egypt never goes. It is so beautiful. Just as an anecdote, I would like to say, many a times I would see these designers design clothes and use combinations with turquoise, with mustard, and I always wondered, where do they get inspired? How do they get inspired to use such beautiful colors? Then I came to Egypt, and I saw it was all on the walls of Egypt. So yeah, beautiful, artistic country with so much culture. So thank you guys for having me back again. Now, what do we want to talk about? We will review the classic benign lesions in young women. Why? Because many a times, cancers in young women have overlapping features with benign features. Therefore, we want to compare how it looks in comparison to a benign lesion, and then describe how we work up or make a decision to biopsy or not biopsy. Then describe the challenges and opportunities in the detection and treatment of breast cancers in younger women. Okay, what does the ACR appropriateness criteria say? At the outset, let's have this clear. ACR appropriateness criteria says that any woman presenting with a palpable lesion should have a thorough clinical breast examination, but because many breast masses may not exhibit distinctive physical findings, imaging evaluation is necessary in almost all cases to characterize palpable lesions. Okay, so gone are the days where a clinician could palpate the breast and say, nothing to worry about, it must be hormone-related changes, just go home. No, that is very, very unsafe. Okay, we have to understand that less than 20% of palpable lumps are cancerous or precancerous. Rest all are benign. But new onset palpable lump is the most common presenting sign for breast cancer. Of all the breast cancers that we see, 10 to 11% happen in women less than 45 years. Okay, these are the early onset breast cancers. Younger age, advanced stage, and aggressive disease. This is not a good combination. And therefore, breast cancer has become the leading cause of cancer death in younger women. This is an acute loss for the socio-economic productivity and critical disruption of family life. When a woman of the family dies, the entire family crumbles. Therefore, it is so crucial that we understand this problem and we deal with this problem. Okay? What are some of the factors that we want to look at? Age. Younger age at diagnosis is an independent risk factor for poor prognosis. And the interesting thing about this younger age breast cancers is 90% of cancers happening in women under 40 years of age happen to non-carriers, women who are not BRCA mutation positive or germline mutation carriers. Okay? They are average risk women who have absolutely no family history of breast cancer or very insignificant family history of breast cancer. And only 10% of cancers happening in younger women happen to carriers, that is BRCA mutation carriers, who are generally considered high risk. Okay? But the high-risk women have escalated screening. Therefore, their cancers are getting diagnosed in relatively good time. However, average risk women below 40 years of age have zero screening. The disadvantage of that is they are detected clinically, means only once there is a new onset palpable lump or nipple inversion or some kind of sign or symptom. And when they're detected clinically, they're usually at advanced stage. Molecular subtype also plays a big factor. Dr. Jennifer Leung gave a superb lecture on molecular subtypes. But what we need to understand here is, in this age group, maximum number of cancers are HER2 positive and triple negative, TNBC. This is the most aggressive tumor biology. And this aggressive tumor biology has overlapping morphologic features with benign lesions, okay? Therefore, that also poses a diagnostic challenge for us. Should we biopsy every lesion that we see in a young woman? We can't, okay? And therefore, looking at subtle signs, looking at those little signs becomes important for us. And regardless of tumor subtype, women under 40 years of age, even in treatable breast cancers, they have higher recurrence rates and worse prognosis, okay? It is important to understand here, like, what happens in under 40 years. The TNBC, triple negative breast cancer, and HER2 positive cancers, they account for almost 50% of the cancer burden in this age group. As against this, women above 40, less than 30% of them are biologically aggressive cancers, okay? Therefore, there is that much difference in the outcome. Now, let's look at some classic lesions. This is a 25-year-old, presents with a palpable lump, upper outer quadrant of the right breast. We see a nice ovoid mass, smooth margin, uniformly hypoechoic, parallel to pectoral muscle, literally as if it has read the textbook, correct? It is a very classic lesion. Most common cause of breast masses in women under 35 years of age, with an incidence of 50 to 75%. This is a fibroadenoma. This is what a fibroadenoma would look like. A woman in her 40s, palpable lump in the right breast, ovoid, gentle lobulations, uniformly hypoechoic with some non-uniform cystic spaces. Then we worry about a phalloides tumor. It could be benign, it could be malignant, okay? Nonetheless, this is not that worrisome. But here is a 27-year-old, 6 months postpartum and lactating. This also looks like an oval mass with a partially circumscribed margin, okay? But one margin has microlobulations, okay? Now look at the three subtle signs. In a fibroadenoma, it is oval, phalloides oval, triple negative cancer oval. Shape is almost the same, but when you look closely at the margins, in a fibroadenoma, it has very smooth margins. In a phalloides, gentle lobulations, like the animal crackers. And in a triple negative breast cancer, like the Ritz cookie, we call it the Monaco biscuit. So train your eyes to look at the margins. These are the subtle signs that will tell you, okay, I need to biopsy this lesion. What are the other things? Here's a 40-year-old, palpable lump in the right breast. When we do the ultrasound, anechoic mass with smooth margin, posterior through transmission. It looks like a simple cyst, okay? Normally, we don't aspirate cysts. We aspirate them only if they get very large or very painful, okay? But now, here's another 39-year-old, and we see a new onset palpable lump, which corresponds to a well-circumscribed mass. It almost looks anechoic, and it also has posterior through transmission. How do we know that this is not a cyst? Always remember to scan through the lesion properly, okay, the entire lesion. Always remember to look for axillary lymph nodes. Color Doppler may sometimes help if you see vascularity, because cysts typically won't show vascularity in the center of the lesion. And this turned out to be a triple negative cancer, okay? So the older rules, like sometimes, long time back when we were in med school, they used to teach us that posterior through transmission, circumscribed oval masses, benign lesions. That is not true anymore. Oval masses, neither oval masses nor posterior through transmission is a confirmation of benignity, okay? So let's review the molecular subtypes a little bit. All the cancer treatment these days happens as targeted treatment, okay? Therefore, understanding the molecular subtypes and from the molecular subtypes, understanding imaging becomes important. Luminal A cancers, which account for almost 56 to 60% of all cancers, they are ER/PR positive, HER2 negative, with low Ki67 levels. Their prognosis is generally good because they are low-grade cancers and lower incidence of recurrence. Okay? However, when they metastasize, we find that they typically metastasize to the bones, not to the solid organs. Luminal B type, they account for 15 to 20% of cancers. They're typically ER positive, PR negative, HER2 negative, and they may have a higher Ki67. Ki67 indicates the proliferative index. They are intermediate to high grade, worse prognosis than luminal A, and with a higher recurrence rate. Luminal B-like, they can be ER positive, PR positive or negative, HER2 new positive, and Ki67 can be variable. They grow faster than luminal A and have a slightly worse prognosis. The HER2 enriched, the offenders in the younger age group, they are ER/PR negative and HER2 positive. They have a high Ki67 level. They grow faster than the luminal subtype, higher grade, worse prognosis. They metastasize to the brain and visceral organs quickly, okay? But they can be successfully treated with chemotherapy and targeted monoclonal therapy. Triple negative cancers or basal cancers, they account for 8 to 37%. They are ER/PR HER2 negative, high level of Ki67, the most aggressive of the lot, higher grade, worse prognosis, mets to brain and lungs are very common, and they are typically associated with BRCA1 carriers. You know, they are called typically the caretakers of the BRCA1 mutation. Means maximum number of BRCA mutation cases will be TNBC, triple negative cancers. Okay, so now let's look at some cases here. This is a 23-year-old who presents with a new onset palpable lump in the inferior left breast. Okay, she says that she feels that it has been growing, the lump. It corresponds to an oval mass. Some of the margins are smooth, some are lobulated. We cannot really assess, okay? But we are concerned. We recommend a biopsy. Patient is unwilling for a biopsy at that time, but she says she'll undergo an MRI. On MRI, what do we see? We see a lesion which is hyperintense on T2. Conventionally, T2 hyperintense lesions were supposed to be benign, wasn't it? Simple cysts, fibroadenomas, okay? But here is a twist in the story, okay? When we look at the subtracted images, there is rim enhancement. There is peripheral rim enhancement, and the mass washes out on dynamic post-contrast sequences. When we actually look through the lesion, like completely scan through it, you see how terrible the margins are. Okay, this was in keeping with a triple negative breast cancer, TNBC. Okay. Now, how do we make our decision when to biopsy, when not to biopsy? What are the subtle signs that we can depend on? I'm going to show you two cases here. This is a woman in her 30s who presents with a new onset palpable lump in the right breast, late 30s. This corresponds to an oval mass. Mammogram is performed and tomosynthesis is also performed. On the mammogram, it corresponds to an oval mass with relatively smooth margins. But notice the posterior margin. Do you notice the peripheral spiculations? Almost like a comet tail sign, right? That is there. So this was biopsied, and it was in keeping with invasive duct cancer, ER/PR HER2 new negative, a triple negative cancer, TNBC. Similar age group, okay? Another patient presented within the next couple days, okay? Late 30s, new onset palpable lump. We do an ultrasound. We are almost convinced that we are dealing with a fibroadenoma. But they say, you know, once bitten, twice shy. We had already seen this case where it had turned out to be cancerous. So we did a mammogram, tomosynthesis. On tomosynthesis, the margins look absolutely smooth, okay? And we did a biopsy for this one also, and this turned out to be a fibroadenoma. Now, if you look at the two cases closely, you will notice that they are both oval in shape, okay? They have smooth margin, fibroadenoma, but on tomosynthesis, the TNBC has this peripheral spiculations. Remember what we discussed in the earlier lecture? When there is a cancer, there can sometimes be desmoplastic reaction. At least some amount of desmoplastic reaction gives rise to those peripheral speculations. But TNBCs grow so fast that the classic speculated mass can't happen. Okay, it's predominantly oval with minimal peripheral speculations. Okay, but when you see subtle signs, microlobulations along the margin, you see a relatively smooth margin, but not a perfectly smooth margin, then remember to have a high level of suspicion in the younger age group. High level of suspicion, and do a biopsy if need be. Triple negative cancers. What are the imaging features? On mammography, these are the women who have dense breast. But within the dense breast, we tend to see round or oval masses with pseudo-circumscribed margins. They typically don't have microcalcifications. Ultrasound has a higher sensitivity simply because in younger age group, the mammogram is denser. But be aware, small TNBCs can mimic fibroadenomas. We may not be able to assess the margins so thoroughly in smaller lesions, okay? Therefore, make an extra attempt to carefully assess the margin, okay? Are there speculations? Are there microlobulations? Is there any irregularity along the margin? MRI has the highest sensitivity. These masses, however, are T2 hyperintense, so don't get fooled by the T2 hyperintensity in these masses. And they can be round, but rim enhancement because of central necrosis can help us make that diagnosis. Okay? We saw this case yesterday. This is the 32-year-old female with new onset palpable lump in the right breast. This was a biopsy-proven TNBC. On MRI, it corresponded to a multifocal breast cancer. Okay? She opted for a right mastectomy for treatment and left prophylactic mastectomy. And within a year, she came with palpable nodularity, which corresponded to this recurrence, okay, seen as linear non-mass enhancement. So in these cases, the recurrence rate is also high. High risk of early local and distant recurrence. And that recurrence peaks between 1 to 3 years after treatment. Okay, so the initial few years, be very, very thorough when these patients come for follow-up. Higher near-term mortality also than most other cancers. Therefore, close clinical and imaging surveillance in the first few years becomes paramount. Despite overall poor prognosis, their response rate to neoadjuvant chemotherapy is very good. Okay, so you will often see pathologic complete response, and which is associated with improved long-term outcomes. But distant metastatic pattern is very peculiar. They have a predilection for brain and lung mets. So if these patients return with headaches, not feeling right in the first few years, don't be afraid to discuss with the referring physician and ask for that MRI of the brain, okay? Because that is the only sign they will present with, okay? Headaches, I don't feel right. I don't know why the headaches don't go. So be aware that these are the tumors that metastasize to the brain. They have poor clinical outcomes in late stages, okay? Now, this was also the case that we saw yesterday. This 35-year-old who had a metastatic left axillary lymph node. She also got COVID during treatment, but she completed chemotherapy. And she responded very well. She fought COVID, she fought triple negative breast cancer, and sometimes these patients will make remarks like, I did this for my child, okay? And then the job becomes worth it. Like, you help them fight their fight, okay? What about HER2 positive cancers? This is a 30-year-old. She presents with painless palpable lump in the left breast. Do we see anything? Do we see a fibroadenoma or a suspicious mass or anything at all that we can call a mass? Very hard to say. Very hard to say, especially on a busy day, you're wondering, what am I seeing? Okay? In such cases where you can feel a palpable lump, always remember to palpate what your patient shows. They will show you. You ask them, how do you feel the lump? When they lie down, they probably can't feel because the breast is like sagging down. She will tell you, I felt it in the shower. When I was taking a shower and I had put soap all over myself and I moved my fingers over it, I noticed it. I actually make them stand up and I say, do exactly what you did when you were in the shower. Okay, and they'll show you, my hand was like this and this is what I felt. I put my hand there, palpate the area. You clearly feel the lump. Then you ask them to lie down and scan that spot. Okay, so that You don't miss the cancer yourself, okay? In this case, even though the findings on ultrasound seemed equivocal at the first shot, we did a mammogram. On mammogram, what do we see? Extensive pleomorphic microcalcifications in the upper outer quadrant of the left breast. This was in keeping with multifocal high-grade DCIS with invasive cancer, ER negative, PR negative, HER2 positive. Okay, this was that classic HER2 positive cancer. So what's up with the radiation? Now, when you tell a 30-year-old to have a mammogram, first the patient who has done a Google search and come to you will ask you 10 questions. Is the radiation going to harm me? Then the referring clinician, if it's a gynac or a GP, they will call you and they will say, the patient is calling me back. She's saying that you're making her do a mammogram. Okay? So at that time, it is important for us to understand so that we can explain to the patient as well as the referring physician that one mammogram is not going to cause her any harm, but a delayed diagnosis of breast cancer will cause her harm. Okay? It will take her life from her. An average mammogram has a radiation dose of 0.0004 gray. You know what is the fatal dose? Above 5 gray. To reach that fatal dose, a woman would need to have 12,500 mammograms in her life, which never happens. And for some context, in Hiroshima, the amount of radiation that was given was 9.4 gray. So with one mammogram, they are never going to reach those levels of diagnostic mammogram. We are not talking about screening mammograms from 20 years of age. We are talking about that one diagnostic mammogram. You make the patient understand, make the referring clinician understand, do it, because it will help you come to a diagnosis, okay? Here's a 31-year-old. Again, new onset palpable lump in the left breast since 2 weeks. What do we see? We see a spiculated mass in the upper outer quadrant of the right breast with these pleomorphic microcalcification. Does everybody notice all these pleomorphic microcalcifications? Oh, sorry. So these are the pleomorphic microcalcification. On ultrasound, it corresponds to this irregular hypoechoic solid mass at 10 o'clock. But in addition to that, there are multiple satellite lesions, 1 o'clock, 12 o'clock, enlarged metastatic lymph nodes, metastatic appearing lymph nodes. So we are concerned that we're dealing with a multicentric cancer with metastatic lymphadenopathy. In this case also, it was ER/PR negative and HER2 positive. However, did you notice on the initial mammogram that there was something in the other breast too? It looks like a relatively circumscribed mass. Could it be a fibroadenoma in the other breast? The patient is young, okay? So we did the ultrasound. This is what the ultrasound looks like. Does it look like a good lesion? No. It looks like a heterogeneously hypoechoic mass. There are lobulations along the margin. We did a biopsy, and she had a synchronous contralateral primary, which was a TNBC. So we were dealing with two separate cancers, two aggressive ones, and the treatment was probably not going to be the exact same in this case. But that is the nature of the beast. HER2 positive cancers, what are their features? HER2 positive cancers are more likely than luminal or TNBC to harbor extensive high-grade DCIS and hence the calcifications. Almost 60% of HER2 positive cancers will have calcifications. Therefore, mammogram is strongly recommended in younger women where you have done the ultrasound and you have a suspicion of malignancy. The better depiction of microcalcifications, extent of disease, multifocality, multicentricity, as well as contralateral cancers happens better when you have the mammogram. Of course, ultrasound has a better sensitivity, but MRI has the highest sensitivity and a very high negative predictive value. Remember, we spoke about negative predictive value. What does that mean? 100% negative predictive value, establishing absence of disease. 100% accurate. Therefore, rely on the MRI in your younger patients. How is the prognosis in these HER2 positive patients? These are highly aggressive cancers. Again, close clinical and imaging surveillance in the first few years, just like TNBC, is very important. Despite overall poor prognosis, these are sensitive to a combination of chemotherapy and HER2 targeted monoclonal therapy. They have a 75% success rate with complete pathologic response, 1/3 reduction in mortality rate, and 40% reduction in recurrence rate. So they respond well to treatment. However, the sad part is the distant metastatic pattern. again, to brain and to viscera. And late stage diseases, usually, although they are chemosensitive than the other subtypes, but the prognosis remains a little bit scary. What about luminal cancers? Here is a 24-year-old, painless palpable lump in the left breast since 2 weeks. Okay, because she was 24, we first did the ultrasound. On ultrasound, we see this irregular mass. We see some satellite lesions. We see an enlarged lymph nodes. Okay, therefore, we decide to do a mammogram. What do we see on the mammogram? On the mammogram, corresponding to the palpable lump, there is a dense spiculated mass with pleomorphic microcalcifications. In the contralateral breast also, there is a mass. Okay, we decide to biopsy. On biopsy, it turns out to be an invasive lobular carcinoma grade 2, which is ER/PR positive, HER2 negative, with a Ki67 of 14%. Okay, look at the pleomorphic microcalcifications here. Okay, so these are the cancers which give rise to these classic spiculated masses. Another 39-year-old. She complains of dimpling on the skin since a few days. When she stands up, she notices that there is a dimpling in the lower inner quadrant of the right breast. She has a very dense breast, okay? Very hard to see anything on this breast. But nonetheless, ultrasound correlation corresponds to an irregular hypoechoic mass in that location. A few other masses are also seen. We perform a biopsy of all the masses. Only the one in the lower inner quadrant turns out to be an invasive lobular cancer, which is ER/PR positive and HER2 negative, so a luminal A-type cancer. And the rest of the lesions turn out to be fibroadenomas, okay? Is it good news? Should we stop here and send her to surgery? Not yet. Look at how dense the mammogram is. Therefore, MRI is performed. On MRI, look at the extent of the disease, okay? Originally, the cancer seen was about 1.5 centimeters. And now, look at how extensive the non-mass enhancement is. It's involving almost the entire lower inner quadrant of the right breast. There continue to be these fibroadenomas, but nonetheless, patient decides to undergo mastectomy. Okay? On mastectomy, what happens is, with the axillary lymph node dissection, out of 23, 19 lymph nodes are positive. And these lymph nodes did not look as concerning. Remember in yesterday's lecture, Dr. Jennifer Leung said that in invasive lobular cancers, we find that even subtle irregular cortical thickening is a bad sign. Okay, so these are very, very aggressive in how they spread. So a little bit about these luminal cancers. They form the classic spiculated masses. Mammogram must be performed in these cases. Ultrasound improves the sensitivity, but again, MRI has the highest sensitivity for assessment of extent. So what is the prognosis and treatment? Now, these have turned out to be the scary types. Hormone receptor positive luminal cancers are the fastest increasing subtype in this age group. Less than 40 years of age, luminal cancers, means which we thought were the good cancers, they have a poorer survival rate. Now, this is a point everyone needs to understand. We always assume that ER/PR positive was good. These patients are going to do well. But in the younger age group, they have poorer survival rates. They are not, in this subgroup, they're presenting with stage 4 disease, Mets to bones, okay? They have a higher histologic grade in terms of Ki67, the proliferative index is also higher. De novo increase in stage 4 disease in this subset, luminal A, HR positive, hormone receptor positive cancers. As compared to the hormone negative cancers, the hormone positive cancers have a 45-month survival rate, median survival rate with stage 4 disease, and 25 months for hormone negative cancers. However, the 10-year overall survival in both groups is less than 20%. But the important point to understand is, in this age group, 25 to 39, cancer survival rate with distant disease is about 31%, and with loco-regional disease, means metastatic lymph nodes, is about 87%. Therefore, it becomes paramount that we find these cancers early, which means before they spread to the nodes. And how are we going to do that if we are not screening these women? Okay, they are only going to come to us with palpable lumps. So this is an area of work for all of us. How is this different from, how do these BRCA carrier cancers behave differently from non-BRCA carrier cancers? Some important points here. In BRCA mutation carriers, they are predominantly triple negative cancers. They can, BRCA1 patient especially, BRCA2 can be ER positive and HER2 negative. But in non-carriers, less than 40-year-olds, they are predominantly prone to triple negative and HER2 positive, the most aggressive subtype, almost 50% of them. Screening guidelines are well established for carriers, but for non-carriers, there are no screening guidelines, so patients are not aware at all. Treatment is also well established in form of risk-reducing surgeries like prophylactic mastectomies, oophorectomies. But in average risk women, why will we do any such thing for younger women? Just because one day you can develop breast cancer, we can't do such a thing, okay? Prognosis, because of all this surveillance in the high-risk group, BRCA carrier group, is good because they're constantly under surveillance. But in those non-carrier group, the prognosis is worse, simply because they are caught at an advanced stage and they have aggressive tumors. So what do we do? What are the challenges and what are the barriers? Less than 40-year-old breast cancer death is disproportionately high in developing countries, countries like Egypt, India. Why? Because there is inherent disparity beyond screening. It's not only about screening, but it is about lack of awareness, it is about lack of resources, it is about healthcare disparities, okay? But what can we do to make this better? A few thoughts. But before that, does race and ethnicity have anything to do? Research and evidence proves that in women less than 40 years of age, in the Black and Hispanic women, there is a 3 times higher incidence of breast cancer in women less than 40 years of age. In addition, there is 61% more likelihood to have triple negative cancers, 61% more likelihood, okay? Higher proportion of stage 3 and stage 4 disease. So this is the subgroup where when we take preventive action, we have to take this into account, that in this subgroup, what can we do differently so that we can catch these cancers early? What is the impact of all this? Of cancers in young women? Greater psychosocial morbidity, poorer quality of life. There are so many real-life decisions involved. Decision regarding reproductive health. Doctor, I have 1 child. I was hoping to plan my 2nd child. Can I still have a 2nd baby? They don't know what triple negative cancer means, but they want to have a family. So, decisions regarding preservation of oocytes. It comes at a cost, a huge cost. This is not covered under any insurance, at least not in India. Concerns are also real-life concerns about body image, about sexuality, about relationship. We are all women. We can understand this factor. Every woman gets concerned about this. Besides, there is higher risk of recurrence. After all this treatment also, what is the guarantee that the cancer is not coming back? We know there is a very high likelihood that it will come back. So what are the strategies? Do we have any strategies? One of the most basic strategy that we can do at 0 cost is population-wide early breast cancer awareness. Every woman, young girls, older girls, I've had 2 patients, at least 2 patients, where the young girls were telling their mother, Mom, I feel a little lump in my breast. And the mother was like, what are you talking about? Young girls don't get cancers. Okay, she waited for 6 months and then she came to the clinic for further investigation. So even like educated women are not aware that cancers can happen to 24-year-olds. Okay, so having that awareness amongst the population that if there is a lump, it needs to be evaluated. But this awareness need not be just within the general population, even for our medical community, because oftentimes we find that gynec doctors or general practitioners, they will palpate and say, you're in the week before your period, it must be hormone-related change, take vitamin E capsules, come back 6 months later. In 6 months, she has metastatic axillary lymph nodes. So that awareness has to be in the medical community too, okay? Potential early supplemental screening in high-risk patient. We don't know how we can supplement average risk, but NCCN recommends that annual clinical breast examination after 25 years of age. Go to your doctor, go to your gynec doctor, go to your GP and get your breast examined so that at least they can find the lump and you can be set for further investigation. So at least that can be done. Okay, where do we start? For this audience, I would say start by reading this article. These two articles, brilliant, brilliant, brilliant articles. Okay, non-BRCA early onset breast cancer in young women. It's a review article in Radiographics. And then there is an invited commentary about it, about the challenges of early onset breast cancer. Thank you guys for calling me to Egypt and giving me this talk, because it made me read so much about early onset breast cancer that even I got some education through the process while making this PowerPoint presentation. So start by reading this article so that we learn about how we can diagnose these cancers in young women. And remember, these early onset breast cancers, how can we, like we spoke a lot of things, but I think the places we can immediately start is early education and awareness amongst the general population, amongst the medical community, to mitigate delay in diagnosis. Be aware, as radiologists, we have to be aware of the overlapping features with benign lesions so that we don't assume. You know, sometimes we don't want to assume, but it is such a busy day at work. There are so many patients, one after the other, localization, biopsy, stereo, and then there is this young girl with a palpable lump. It is oval, it is, maybe I should just call it a fibroadenoma. No, don't do that, okay? If at all, just do that one extra biopsy. It may save that woman's life. Timely diagnosis and treatment are cornerstone for improved survival rate. And this is one of my young patients. It will take only 2 minutes, but what does it mean? She's a 24-year-old. When she was diagnosed, and she has been very kind to be the poster girl for the younger women for our cause. When she came for a diagnosis, and I told her mother that this and this is what we are dealing with, her mother also couldn't fathom the totality of the situation. She was like, but doctor, she's about to go for her master's to university, which starts next month. So everything will be done in 1 month, right? And I didn't know what to say. Like, we are talking about breast cancer, so the treatment is going to go on for at least a year. This girl, she completed her treatment for the year, and then she went for her master's. She completed her master's, and last month she also got married. So these are the inspiring stories which make us go on. But you must listen to her story first. 1 second. Okay. You will need to help me here. Sorry, I normally use Max, so Merit. Maximize, yeah.
Hello, my name is Tanisha, and I was diagnosed with stage 3 breast cancer last year in October at the age of 24. I know, shocking, right? I always thought that cancer was the kind of thing that happens to other people. It was never going to happen to me, not at the age of 24 anyway, until it did. The journey after that day feels like it was right out of a movie. It was so unreal. While the whole world was battling COVID-19, I was fighting cancer. But the whole of last year has been a learning curve for me. I have learned a lot, and the experience has taught me a lot of things. Most people think that cancer is always hereditary, but that's not necessary. I was asked to do a genetic test, and it was negative, which means that I didn't get it from anyone in my family. It was a bit confusing, really, but while this may sound a little morbid, it proves that it could happen to anyone, and it doesn't have to be hereditary. After my diagnosis, when the treatment started, I had to undergo a total of 16 cycles of chemotherapy, along with surgery and radiation therapy, and now I'm on hormone therapy, which is going to continue for a few years. Things were difficult, but everything helped me discover inner strength that I didn't know I had. And the most surprising part was that I was quite calm through all of it, which surprised me the most. What I did learn from this experience is that the faster we accept the reality and decide to face this mammoth challenge, we can come out stronger and beat this. The more we delay this, it'll keep building up in our mind and things get even harder. Success stories make for great motivational fuel, and just as they were a great source of strength and inspiration for me, I hope that I can be a guiding light and support for others who will be going through a similar situation. Remember that you are not alone, and please stay safe, stay healthy, and wish you all the best. Don't delay treatment, and trust your doctors, keep your family and friends close, and All the best.
Thank you very much for your kind attention. But putting real life into the work that we do makes our work worthwhile. So I thank you for your kind attention and thank you for having me here.